Imagine this: you're prescribed medication to help with your mental health, but instead of feeling better, you face unexpected challenges in the bedroom. Today, we're diving into a topic that affects millions: the link between antidepressants and sexual dysfunction. Stay tuned to uncover the science behind this often overlooked side effect and discover solutions to reclaim intimacy and well being. Hello, everyone, and welcome back to PharMed Academy channel. In today's video, we will discuss sexual dysfunction caused by antidepressant medications. We'll review different antidepressant medication groups and the etiology of sexual dysfunction caused by them as our introduction. Then we'll discuss how this happens, and then we'll go through 6 effective tips to manage these annoying side effects. If you enjoyed this video, please give it a like and subscribe to my channel. I also have a bonus tip for you about the comparison of antidepressants in terms of their sexual dysfunction side effects, so make sure you watch to the end of the video. Selective serotonin reuptake inhibitors, or SSRIs, are commonly used as first-line antidepressant for various psychiatric disorders. However, these medications can negatively impact different aspects of sexual functioning, such as desire, arousal, and orgasm. Sexual dysfunction caused by SSRIs can occur in both male and females and may even fail treatment. Sexual side effects can occur with other classes of antidepressants, including serotonin norepinephrine reuptake inhibitors or SNRIs, tricyclic antidepressants or TCAs, and monoamine oxidase inhibitors or MAOs. However, there are more studies of sexual dysfunction secondary to SSRIs. That's why we based this video around data on SSRI sexual dysfunction side effects. The SSRI category of medications includes sertraline, citalopram, escitalopram, paroxetine, fluoxetine, and fluvoxamine. In an observational study of more than 1,400 patients treated with citalopram, results showed decreased libido occurred in 54%, difficulty achieving orgasm occurred in 36%, and among 574 males, erectile dysfunction occurred in 37%. The most common sexual side effect of SSRIs is delayed ejaculation. Because of this effect, SSRIs have been used off-label to treat premature ejaculation. Now let's talk about how SSRIs cause sexual dysfunction. The reason is not completely clear, but there are some theories for this side effect. SSRIs increase serotonin levels by inhibiting presynaptic reuptake of serotonin, with minimal effects on norepinephrine and dopamine uptake. Citalopram, escitalopram, and fluvoxamine only affect serotonin, but paroxetine, sertraline, and fluoxetine affect serotonin, norepinephrine, and dopamine. Delayed ejaculation is frequently associated with SSRIs and usually is not caused by depressive disorder. Animal studies show that increased serotonergic tone predicts ejaculatory latency by acting as an inhibitor at the hypothalamus level. In contrast, noradrenergic tone enhances ejaculation. So antidepressants that increase noradrenaline levels and serotonin levels, such as serotonin norepinephrine reuptake inhibitors, induce milder ejaculatory delay. An increase in serotonin levels can affect other hormones and neurotransmitters, such as testosterone and dopamine. This can lead to sexual dysfunction, as testosterone is involved in sexual arousal and dopamine is essential for achieving orgasm. Also, SSRIs may reduce levels of nitric oxide, which is necessary for mediating penile vasculature changes needed for erectile. The first tip for management is watchful waiting, which means waiting 2 to 8 weeks for a spontaneous remission of the adverse effects. Although for SSRI-induced sexual dysfunction, it appears that watchful waiting alone is typically not effective. If sexual dysfunction continues, we recommend decreasing the medication dose within the therapeutic range as our second tip. Remember that reducing the dose may diminish therapeutic effects. Therefore, the dose should be decreased slowly and in small increments, and not be reduced below the minimum therapeutic range. The third tip is for patients who experience serious sexual side effects or don't respond well to antidepressants. For these patients, switching to another group of antidepressants is recommended. The following choices are usually bupropion or mirtazapine because they showed lower sexual dysfunction as a side effect. Switching to another SSRI is also an option, especially in patients who were satisfied with previous SSRIs. But with this, the decrease in sexual dysfunction might not be very different. The fourth tip is adding medication. For patients with improvement in depression with their antidepressant medications and mild to moderate sexual dysfunction, we recommend adding another medication to control sexual dysfunction. For males with erectile dysfunction, we suggest adjunctive treatment with phosphodiesterase 5 inhibitor medications like sildenafil and tadalafil. I created a video discussing the use of PDE5 inhibitors in erectile dysfunction. I put a link in the video description if you are interested in watching that video. For females with low libido, we typically suggest add-on bupropion at relatively high doses within the therapeutic range. For example, bupropion extended release 300 mg per day. For females with delayed orgasm or anorgasmia, which is the absence of orgasm, we suggest a phosphodiesterase 5 inhibitor. In general, switching medications is better than augmentation because adherence may be better with monotherapy than with combination treatments. Other effective methods are exercise and drug holidays. Exercise for 30 minutes of moderate strength training and cardiovascular exercise 3 times a week. Drug holidays can also be helpful. Drug holidays stop treatment for a short period, but also reduce the efficacy of treatment in general. This method is not practical for fluoxetine users because of fluoxetine's long half-life, which is about 2 weeks. The last tip is to schedule sex. Your medication may produce more side effects at particular times of the day, for example, within the first few hours of taking it. If so, you can try scheduling sexual activity for the time when side effects are least bothersome, or take the drug at a different time. And lastly, here is the bonus tip. There has been few studies comparing SSRI medications to see which one has the least and most sexual dysfunction side effects. If we want to rank SSRIs from best to worst based on their sexual dysfunction, it would be like this: citalopram and escitalopram, then fluoxetine, sertraline, fluvoxamine, and paroxetine. Thanks for watching this video. I hope you enjoyed it and learned something new today. Please like and share this video and subscribe to my channel for more content. See you in the next video.